Good afternoon, everyone. I'm Tammy Wickman, and I want to welcome you all to Grand Rounds. I'd like to thank Dr. Romberger and the Planning Committee for letting us in education have this Grand Round, and it's now going to be annually, so we're excited about that. Before we get started, I would like to take a minute to remind everyone about Jared Dye. The third anniversary of his death by suicide was on Sunday. And as it's the third and our residency runs in 3 years, not everyone remembers Jared, but he was an amazing physician. He was going to join us on faculty and a wonderful human being. And we want to recognize him and honor his memory, and also just raise awareness of the hard times that everybody's been going through, and that being a physician is a tough job, and that there are lots of resources out there if you are struggling. So I'd just like to take a minute before we start Grand Rounds to just honor Jared Dye's memory. A minute seems much longer on Zoom than it does in person, but I thank you all for remembering Jared, and to remember to raise up each other in our struggles. And now it is my distinct pleasure to introduce our speaker today. Dr. Marcelin is from the Infectious Disease Division, and she grew up in the Caribbean and did her medical school there, and then went to Mayo for her internal medicine residency, and then stayed on for her infectious disease fellowship. And we were lucky enough to recruit her to University of Nebraska several years ago. And then I was lucky to have her join my team in education as one of the associate program directors. And over the last 2 years, she's been an amazing addition, challenging us to always be better versions of ourselves. And so I know this Grand Rounds will be amazing, and she's going to talk to us today about diversity, which is a huge topic for the ACGME in addition to society in general. And so I'm excited to hear her talk. Thank you so much, Jasmine.
Thanks for having me. I'm excited to be here too. Is my volume okay? Thumbs up? Okay, good. So today we're going to dive into a topic that I'm really very passionate about, and I am excited to take this journey with you. It will be interactive using Poll Everywhere. And so there was some instructions in the beginning, and I think Shannon has put some instructions again into the chat for anyone who needs the instructions for Poll Everywhere. And I think when the polls come up, there'll be some instructions as well. All right, so why do I pick this as my opening picture? I don't play chess, but I recently binge watched the Queen's Gambit on Netflix. And that had me thinking about just parallels with the game of chess and the diversity, equity, and inclusion journey in medicine. So there's an opening, there's a middle game, and there's an end game in both of them. It requires tons of focus, practice, determination, and sometimes it seems like an impossible task. However, when decisions are based on data and outcomes are anticipated and prepared for, and the players exercise patience, they can reach their ultimate goal, which is to win or checkmate. A mistake in chess is, just a loss, although chess players might come at me with this. I think some people are really passionate about chess. But in medicine, mistakes relating to equity and inclusion can be costly. So here are today's objectives. We'll start with a brief history of what it means to be underrepresented in medicine. We'll then describe the current landscape of diversity in graduate medical education, impacts of the lack of diversity on trainees, and then wrap up with some examples of how to address this in GME. So I have no relevant disclosures, except for my usual disclosure when I'm talking about these types of topics, when I say that, there are opportunities during this time that we have together in the next 50 minutes or so that you may feel uncomfortable. And I just invite you to sit with the discomfort, really kind of take a curious approach to it, and think about how the things that I'm talking about can relate to your training programs, regardless of what stage of training, or even our interactions with patients or other folks or people in hiring positions. So before we jump into things, there will be some terms that I'll be using frequently throughout this presentation. So I thought I would just define them up front. So DEI and JEDI. So DEI stands for Diversity, Equity, and Inclusion. And JEDI is another play on that when you add justice. And so the JEDI acronym stands for Justice, Equity, Diversity, and Inclusion. So what is diversity? Diversity means having different people present in the room. So we're going to take this room analogy over the next couple definitions here. So diversity is having them present in the room. Inclusion is having different people in the room be able to speak and to be heard. Equity is having everyone have the opportunity to enter the room in the first place and speak. And justice is removing the door to the room altogether so that anyone can go freely. Moving away from the room analogy, structural racism is something that I mentioned throughout this talk as well. And I don't go into a whole lot of details into it because one of our excellent seniors, Dr. Willie Talbert, did have a fantastic senior seminar on Wednesday talking a little bit about this. But when we're talking about structural racism, what we mean are the systems that perpetuate and reinforce racism within our country, within our society. And lastly, when we talk about unconscious or implicit bias, what we're referring to are unconscious beliefs about groups of people that affect behavior towards those groups of people. Okay, so this is the first poll. I just wanted to get a lay of the land to see who is part of this presentation listening here today. Do you belong to an underrepresented minority group? And for the AAMC definition, URM is meaning those racial and ethnic populations that are underrepresented in the medical profession relative to their numbers in the general population. Generally speaking, we're talking about people in the Black community, Hispanic, Native American populations, and Pacific Islander groups as well. And so if you, based on your personal identification, feel like you identify as a member of an underrepresented group, answer the poll here. Okay.
It looks like you have Dr. Woodard raised her hand. If you have
Somebody's raising their hand. Let's see. Oh, okay. I can't see if you're raising your hand, but I appreciate the hand raising. And if there's any issues with seeing the slides, just let me know. Okay, so what we're seeing on this is about, it looks like a quarter of the folks that are here on this call together are identifying as members of underrepresented groups, and 3/4 are not. And that seems to make sense. And actually, if you just think about this group in and of itself, we probably have an overrepresentation of minorities that are participating, which makes me very happy. Hi, everybody. Okay, let's move on from the poll. We're going to talk a little bit about underrepresented in medicine. So like I mentioned, Dr. Talbert did have this excellent senior seminar, and he's focused on disparities in healthcare in the Black community. And the week before that, we had Dr. Cruz presenting about disparities in healthcare in the Hispanic communities. And one of the questions that is at hand is, could having more Black, Hispanic, Indigenous people in the medical profession reduce some of these issues related to disparities in care? And in some cases, even negligent or repugnant behavior by medical professionals. So the short answer is yes. Dr. Talbert shared data where there was reduction in disparities in infant mortality when Black babies were cared for by Black doctors. Does that mean that Black babies should only be cared for by Black doctors? No. But having more Black doctors certainly reduces the likelihood of these disparities being perpetuated. The thing is, a solution of minoritized populations being cared for only by doctors of their race or ethnicity is not reasonable because, well, there are just not enough of us to go around. And that is what we're talking about here today. So let's talk a little bit about this journey. When medical schools first began, women were not allowed in. We recently celebrated Dr. Elizabeth Blackwell's birthday and National Women Physicians Day in February to highlight her as the first woman to receive a medical degree in the United States in 1849. For those who may not know, her acceptance into medical school was actually a practical joke that backfired and paved the way for white women to become physicians. And since then, there has been a gradual and intentional effort to achieve gender equity in medical education, which has paid off because in 2019, for the first time ever, more women than men were enrolled in medical school. And, in 2020, this continues. In 2021, this continues. The journey has been a challenging one, though, for racial and ethnic minoritized Americans. The first African American to graduate from medical school was Dr. James McCoon Smith, but he had to travel to Scotland to be allowed into medical school. Dr. David Jones Peck was the first African American to graduate from an American medical school. That was Rush Medical College in Chicago. It was almost 20 more years before the first African-American woman graduated from medical school in America. That was Dr. Rebecca Lee Crumpler. She graduated from the Female Medical College in Boston in 1864, but this was a full 15 years after Dr. Blackwell. By the late 1800s, there were 10 Black medical schools available, but after Dr. Abraham Flexner published his damning report in 1910, only 2 Black medical schools remained, Howard and Meharry Medical Schools. Since then, 2 additional schools, Morehouse and Charles Drew, later opened in the 1970s, but to this day, we only have 4 historically Black medical colleges in the entire country. And this is what systemic racism looked like. There were no medical schools for Black folks, but they were not allowed to enter white medical schools. So they did not go to medical school. So there were not Black doctors. If you want to learn more about the history of minorities in medicine, University of Alabama has a great webpage that you can check that has a really nice history of how things have progressed over time. So this is in the past, and so let's fast forward to the recent history, where we see that unlike the steady increase of women graduating from medical school over the years, the numbers of Black, Indigenous, and people of color graduating from medical school has remained stagnant over time. Less than 15% of applicants to U.S. medical schools in 2018 to 2019 were from racial or ethnic groups underrepresented in medicine. And of the graduates from that year, 6% and 5% were Black or Hispanic, and less than 1% of graduates were from Native American or Hawaiian groups. So let's talk a little bit more about addressing this problem of diversity or lack thereof in graduate medical education. We're going to talk another poll here. Since this is the topic of the day, do you think that diversity should be an important consideration in the residency selection process? And you have a Likert scale here ranging from extremely important to extremely unimportant and everything in between. And remember, these polls are completely anonymous. I can't tell who's saying what. And so I just wanted to get a sense of the lay of the land and what folks are thinking about this topic. All right, so looks like just over about half of folks thinks it's extremely important, and they say about 2/3 of people think that it's, or just over 75% think it's somewhat important or extremely important, and then some folks neither, and a minority of people I think it's less important. And that's something that is good to see, that there is a spread, because it means that there's stuff to talk about, and there are good conversations that we can have, and hopefully by the end of this talk, I can at least convince the folks who think that it's not important that it's something that they should be thinking a little bit more about. So first things first, it's important to note that the Accreditation Council for Graduate Medical Education, or ACGME, has updated its common program requirements, and there are now specific comments about diversity. So what do we expect from ACGME? They are going to be adding new additions to the resident and faculty surveys that evaluate now the descriptions of intentional processes that are being put in place to develop and retain a diverse workforce. But later, they're going to be looking for actual evidence of achievement of said workforce diversity. So ACGME has communicated that not only does it want us to talk the talk, but it wants us to walk the walk. So when we're approaching the simple problem of numbers, there are a few tension points that have to be considered in the process. So first, it's the recruiting process. Then we're talking about selection, and then the folks that we interview, and then finally ranking of candidates. And at each of those tension points, discussions about values and what are the needs of the community that we're trying to serve and the workforce that we're trying to build in order for us to be able to achieve these goals. All right, I've got another poll for you. When we're talking about the recruiting process, and whether it's at the medical school level or the residency or the fellowship level, or even recruiting faculty, we're thinking about different factors that are important for applicants to be offered an interview. This specific question is focused on graduate medical education, and I'm curious about what those of us in the audience think are the most important factors for applicants to be offered an interview. And it doesn't matter if you are a resident or a student or a faculty yourself. I just want to know what you think should be the most important factor. One of my favorite things watching these polls is seeing how the numbers kind of go up and down. There's benefits and risks to letting the numbers sort of just go up and down like that. But again, it's anonymous. Nobody knows what anybody's putting. And so I just want to know what y'all think. Looks like about a third of our listeners are thinking about letters of recommendation. So what do people think about these applicants? Then we've got about 20% that think USMLE Step 1 scores are the most important thing. And then almost a three-way split between the medical student interpersonal skills and their written personal statements, as well as the MSPE document that's uploaded from their university, from their medical school. So it's a good smattering. There was a survey of internal medicine program directors asking the same question. And so this figure shows the 2020 NRMP match survey. And it showed that 91% of internal medicine program directors cited USMLE Step 1 as an important factor in selecting applicants to interview. The only other factor that had a higher response rate was USMLE Step 2, which was 93%. Just under half of program directors responding felt that the AOA and Gold Humanism Society status were important factors, and we'll talk a little bit more about that later. But the mean importance rating of these were very similar to mean importance rating of Step 1 score, which is about 4. And so that means that even though the numbers may not have been the same, how important it is to the program directors was still pretty high up on the list. For ranking their applicants, interactions with faculty and house staff were the most important factors, but USMLE Step 1 still was relatively important to program directors. And then finally, something that was not assessed in this survey of the NRMP, but nonetheless is a factor that makes its way into consideration, is ties to the state. So how many of us involved with recruiting or admissions to UNMC at any level, medical school, residency, fellowship, post-fellowship faculty positions, have had conversations in recruiting discussions about ties to Nebraska in the candidate discussion? And that's something that you see across the country where it does come up. It may not be as tangible, but it's something that people ask questions about. And it's something that candidates also think about when they're thinking about where they rank as well. So let's talk about Step 1 scores. Disparities within Step 1, USMLE Step 1 is enough itself a topic that could be a talk on its own. But what I will say is that there are a myriad of reports that have demonstrated that USMLE Step 1 does not predict what kind of doctor an individual will become. Dr. Edmond and his colleagues in Virginia found that when USMLE Step 1 scores are used to screen applicants for residency interview, fewer Black students will get an interview. And so we have to think about, what are the things that we're using, what are the gates that we are setting up in order to achieve the goals that we have. As gatekeepers, we have to evaluate each of the gates that we have set up along that way. Fortunately, USMLE Step 1 scores are singing their swan song, and by January 2022, we will say goodbye to them forever. This decision has already been made and it's out of our hands. So what that means is that now is the time for us to be thinking about how to replace USMLE Step 1 with something that is meaningful and not associated with potential bias. Oh, some people already got ahead of us. And so the next question was asking about Gold Humanism Honor Society or Alpha Omega Alpha Honor Society, or AOA. Were you inducted into either of these societies in medical school? If you were inducted post-medical school, that's really great. But this question is really specific to while you were in medical school, were you inducted into either of these societies? it seems that we have a vast majority of folks who are on this call who are saying that they were not inducted into either of them during medical school. There are some medical schools that don't have this. And then if you were inducted into one of these societies, it looks like AOA is the one that most folks were inducted into. This was an interesting a question for me because every year there are discussions about whether or not honor societies in medical school are problematic from a bias and recruiting standpoint. So for those who might not be familiar, the Alpha Omega Alpha Society is an academic society, while the Gold Humanism Honor Society is more of a service society. And so this study found that Black students were roughly 2/3 less likely to be inducted into AOA. And when they excluded board scores from their model, that racial disparity still persisted. When they looked at Gold Humanism Honor Society, they found that there was no difference between the rates of induction of Black or non-Black students into Gold Humanism Honor Society. So back to the original question, are honor societies problematic? Maybe, perhaps not across the board, but it's still important to consider what is the value of honor societies in the currency of residency selection. How do we value them? And should we be valuing them as high as we do if they are high up on our list? Now, I mentioned structural racism very briefly earlier and also talked about Dr. Talbert's presentation on Wednesday. And what I wanted to bring in here with this slide is that structural racism in and of itself can impact students' even entrance into medical school, and it can affect their performance in a number of ways, like inequitable access to test prep services, inequitable access to volunteering opportunities. They have to work more than one job to support a family, constant stress and anxiety from living while being a member of the Black, Indigenous, and people of color communities, inequitable opportunities due to policies like Nebraska Measure 424, which was implemented in 2008. And this measure bans the use of affirmative action policies in state-funded institutions. So what that means is there are limited access to scholarships at universities like UNMC that are earmarked for Black and Hispanic and Indigenous students. And that effectively reduces matriculants to state universities like UNMC, where in Nebraska, where this is a measure, because if the private university will offer the scholarships, you will have students who need the financial assistance will go to the private university. And then this will perpetuate the underrepresentation of these groups at a state university like UNMC. And additionally, once they apply, unconscious bias, again, that's the unconscious beliefs that people have about other people. These can play a role in perpetuating and reinforcing inequities when their applications are being reviewed or they're being interviewed or discussed for ranking afterwards. So all of these mutually problematic factors come together to create an imperfect storm of underrepresentation of these racial and ethnic minorities in residency training. And we must also consider when we use terms like diversity and underrepresented, that these terms do not apply only to race or ethnicity and gender. And because of stigma and bias in application development, we just don't have reliable data on outcomes and metrics for many of our colleagues who belong to LGBTQ+ communities or who are disabled. I actually found it really difficult to find robust data describing the prevalence of LGBTQ+ medical students or residents. And this might be because the community itself is heterogeneous and makes it more challenging to narrow to one figure, or because not all members of this community are out, and they may not be in a position to participate in research like this. But in one study, a survey study of North American medical students, about 15.8% identified as sexual or gender minorities. And many of them responded that they conceal their sexual or gender identity in medical school. I couldn't find similar types of data for residents. In the disability community, we know that the prevalence of reported disabilities in medical students was 2.7% in 2016, and by 2019 had increased to 4.6%. But this also may represent under reporting of disabilities, and requires us to really be intentional about how we think about diversity and inclusion, and how we include these groups that we're not traditionally talking about. So when we consider underrepresented in medicine, we should not just include racial and ethnic populations. We must add that extra plus to include other underrepresented groups like those who are disabled or LGBTQ plus communities. Okay, so let's shift gears a little bit and proceed to the middle game. And for me, I think the middle game here is inclusion. Inclusion in medical training. What does that mean? Oftentimes in the Midwest, you'll find training programs where there is a lone Black or Hispanic resident or a faculty member. From my personal experience, being first only different in my successes may have been attributed to me individually as an expression of exceptionalism. However, my failure can be attributed to all Black women or immigrants or all international medical graduates that may come after me. And that is a lot of pressure that comes with significant cost. Add to that the constant barrage of conscious and unconscious discrimination faced by people with intersectional identities. When these are the constant messages one receives from colleagues, leaders, patients, friends, what are the chances of someone internalizing those messages or feeling like they don't belong where they are when they're the only one? LGBT medical trainees also experience discrimination from their peers, from faculty, from residents, from medical staff, from patients. And the students' perception of the impact of such discrimination differs depending on whether or not one is a member of the LGBT community. And so we have to constantly push ourselves to be asking questions about whether or not the things that we're saying, doing, and accept behaviors that we are accepting are unconsciously hurting other populations. And again, I have to keep saying it, focusing on diversity and inclusion efforts on race and ethnicity can leave disabled trainees feeling left out. And we have to ask ourselves the question, is it really diversity and inclusion if there is no inclusion of disability? Consider what it might be like to be a Black, gay, disabled person in a training program. And then now think about your own training program and whether or not that resident is likely to feel included. How are we making sure that the environment that we are creating for our residents is one where they feel included, regardless of how they identify? These issues can have significant downstream effects. Between 2019 and 2018, the number of all underrepresented women faculty went from 12% to 13%. In 2018, only about 2% of the academic faculty were Black women. Now, I often wondered why I didn't see more women like me at my institution when I was in training, and this is the reason. There is both a pipeline entry and a leak-related issue for underrepresented women. How are we meant to aspire to leadership when we just don't see people like us in those roles? And speaking of pipeline and leaks, this graphic documents the pathway of a woman of color in the workplace. After initial welcoming, if she's the only one or one of a few like her, speaking up about inequities that she may be experiencing or seeing may lead to her being labeled as a problem. This leads to microaggressions and repetitive issues over time that may ultimately lead to her leaving the organization. This particular example was in business, but there are multiple examples of this in medicine, with one of the most recent stories about an internal medicine pediatrics residency program director, Dr. Princess Denner, being fired from her leadership position after filing a lawsuit detailing a decade of race and gender discriminatory behaviors towards her and Black residents in her program. And that included discriminatory ranking processes that disadvantage student residency applications from historically Black medical schools. We're losing talented faculty, and there are not enough of us that are coming up to fill the holes. So this is something that we have to think about from a pipeline issue. How can we make sure that we are growing faculty from underrepresented groups and helping them to stay in academia and feel welcomed and valued in academia? In all of the history of diversity efforts, and particularly in 2020, where we saw the impacts of COVID-19 on the Black and Brown communities, disabled folks being marginalized, anti-LGBTQ plus discrimination. There's been a lot of just institutional statements about diversity and inclusion, but unfortunately, many of those statements are not backed with financial resources to really tackle systemic change and dismantle the structural racism that infects the institutions of healthcare. And there's not a lot of obvious valuation of this work in the currency of academic leadership, which is promotion and tenure. So what that means is this work disproportionately falls upon the very same marginalized people who are obviously passionate and committed, yet receive little or no compensation or recognition for this work. And that is part of the structural change that needs to happen across academic institutions across the country. So, as we're talking about all of this, some might question whether, when we focus on diversity, will we sacrifice quality? The thing is, diversity drives excellence. And there is data that shows that even outside of medicine, diversity on boards of directors leads to more innovation, research and development, and increased firm reputation. And all of that increases the firm's performance. Even if you don't believe anything that I'm saying, you must admit that when there are different voices brainstorming about an idea, there are just more innovative options than if a group of only like-minded people are brainstorming. So diversity is definitely important, but the bias can detract from those goals. I just wanted to shine a light and say that, UNMCES is making some movements, and over the last 18 months have made some pivotal promotions of faculty to maintain momentum. And I'm really proud of the work that our faculty listed on this slide have been doing. In internal medicine, the mission of the Diverse Task Force is to transform our residency into one that reflects the diversity of our patient population and ensure that our residency provides an inclusive environment for residents to succeed. Our task force members include residents, students, faculty, volunteers, and we've met on a monthly basis since January 2020, and we've had a number of different goals. We developed a website and are working on updating it with media and resources from a new DEI section we started in our department newsletter. For intentional recruiting, we participated in SNMA residency fairs this summer, and several of the applicants who came to our residency fairs applied to our program, and we interviewed them. And we also developed DEI virtual roundtables for our interviewees. We're collecting data on inclusion and belonging during residency and have begun a town hall series called Jedi with Jasmine, which is just an opportunity for residents to speak candidly and authentically in a safe environment. The pandemic has curtailed some of our pipeline plans, but we have connected with the Summer Health Professions Program for panel discussions and have a proposal approved for a visiting medical student scholarship whenever we do have in-person visiting students. And finally, we have been engaging in a significant reform of our residency selection committee, the way that we perform resident selection. We revised our criteria for reviewing candidates and offering people interviews. We ensured that every single URM applicant was reviewed. And just to share quickly some of our, just like what we have in terms of data from this year, 15% of our applicants this year were from underrepresented groups compared with 9.9% last year, and 12% of our interviewees were URM, and we've more than doubled the number of URMs that we ranked this year. You know, these numbers are small, but encouraging. It means that we can put our minds to doing things and making systemic change that can have impact. And our work, the process is not complete. You know, this is the ranking certification week. But, you know, all of this will be defined by how candidates ranked us and whether or not the match algorithm is favorable. But it's really important to emphasize that our residency program leadership was all in with having difficult discussions, really talking about what are the values, what are the things that we want, and how can we make sure that our residency program models those values. And finally, to encourage awareness and discussion about racism in healthcare, this pin that I'm wearing was designed by one of our former internal medicine chiefs and current current HEMONC fellows, Dr. Caitlin Muir and I, with an accompanying card with suggestions on how to be anti-racist as a healthcare professional. And each division will receive some pins to distribute. And if more are needed, there are instructions on the card to order additional pins. We're also launching a 21-week racial equity challenge to start this coming Monday with details coming in UNMC today. Okay, so all of this, what is it for? The approach of diversity and inclusion as the end game is more of a let's get the numbers and stop there. But I challenge that. I submit that the end game should actually be equity and justice. To truly address this, GME training programs need to examine and reform their education, reform the recruiting practices, clinical policies, and commit funding to continuous efforts to ensure an equitable and inclusive environment. This framework addresses ACGME standard on diverse workforces, setting diversity as a priority. I propose that one step is missing between implementing inclusive recruitment practices and investing in trainee success, and that is commitment to ranking underrepresented candidates competitively. And similarly, we have to interrogate our own internal as well as institutional GME policies and procedures for supporting disabled trainees. And that starts with just identifying what are the essential functions and reasonable ways for individuals to be able to request accommodations without fear of retribution. Put simply, there is no one-size-fits-all pathway for this endgame. As Dr. Talbert shared on Wednesday, in order for us to treat people equitably, we may have to treat them differently, and that's okay. And that might feel weird, it might feel uncomfortable because our default is wanting to give everyone the same, but we have to treat them differently in order to treat them equitably. So what do equity and justice look like in GME? I think it looks like training programs with residents and faculty who represent diversity of patients and communities that they serve and advocate for their communities because they feel connected to their communities. I think it represents programs that are flexible and nimble and have departmental leadership that are invested and shared with their JEDI commitments. Includes curricula that reflect JEDI values and programs where everyone, faculty, staff, trainees can feel included, belong, and capable of voicing those concerns without retribution and really feel like they can be authentically themselves. So I will end with just a few pearls about what I have learned so far in this process using a different residency program as a case example. So rule number one, learn from others' experiences, right? So here is a case of a diversity snowball effect at an emergency medicine residency in Oakland, California. So they had a goal to match 30% of underrepresented minorities with each incoming class, and also to make sure that their class mirrors the US, at least mirrors the US population in terms of demographic breakdown. And theirs is actually a good success stories. The thing that I learned from them was that they, first of all, reflected on their program values and then assessed their current practices. So they looked at what their criteria, their selection for interviews were, and realized that they were placing additional weighting on USMLE and other areas of academic performance. And they ended up looking at how they can adjust their what they call Gestalt score, which is dependent on qualities that the scorer deems important for success in their residency and as a physician. And they talked a lot about what does that actually mean. And those of us who are in residency leadership or fellowship leadership we all talk about what Gestalt means, but this group actually went and tried to quantify what the Gestalt meant for their individual reviewers. And then they had both faculty and residents that were participating in the interview process, and their scores were treated with equal weight, and any movements when it came for them to rank were done by a majority vote. So there was not one person or two people that could skew things based on any specific biases. They also developed a diversity committee that reviewed all of the URM residents, and they noted that reaching a consensus was not easy. And they had a lot of awkward discussions during the initial rank meetings. Again, that is okay. The fact that they were able to have those awkward discussions and move beyond them into making decisions that were meaningful tells a lot about how invested the entire group was, but it was not easy. So they ended up dropping the USMLE filters, and they increased opportunities for committee members to have more in-depth discussion about what Gestalt actually meant. And then they developed a diversity application week where they brought their URM applicants to campus and allowed them so that they could meet other faculty and really demonstrate how the residency program was committed to them. So the fourth thing that I learned is to set the expectation for accountability. I consider this to be a plan, do, study, act cycle. It's not going to be the big improvement that you want immediately. You're going to have opportunities to receive feedback. When they receive feedback that people felt that they were not being transparent, they opened up the committee to more folks. They set the stage for more authentic conversations, and they kept revising the process so that it could be something that everyone felt good about. In the end, they were successful in increasing the percent of underrepresented residents, and they far exceeded the demographic breakdown of emergency medicine residencies across the country. Here's the kicker. This took a decade, which brings me to my last rule, which is prepare to be in this for the long haul. This is a team job. It requires buy-in from all stakeholders, and it requires time and money to support it. There will be uncomfortable interactions, and there will be times when you want to walk away from it all because it just seems like an insurmountable or impossible task. But stick with it and celebrate the small wins that bring you closer to the goal. Eventually, the hope is that this will not be a heroic effort. But until then, I will leave you here with this poem that is written by a Canadian poet, Rupi Kaur, and I hope that gives you a little insight into why I personally keep doing this work. It's called Legacy. It goes, I stand on the sacrifices of a million women before me, thinking, what can I do to make this mountain taller so that the women after me can see further? So I want to thank you for sharing this time with me, and I'm looking forward to having any kind of conversation you might want to have about this right now, or comments about this process, including what I shared about the emergency medicine program.
That was amazing. Thank you so much. I have to say that this is the busiest chat room that I've ever seen during a Grand Rounds presentation. And so that is awesome. I will try and give you a couple of the points, but I definitely did not get them all down. Lots of people jumping in saying that the pain that you're talking about, they have felt that, and that what you're saying is real. There were some questions about can we continue to have the focus be on Nebraska if we're talking about diversity, and there was also a question about visa statuses and recruitment as well.
Okay. So first of all, I appreciate those who commiserate with some of the things that I was sharing. Focusing on Nebraska and diversity is, we have to acknowledge the fact that Nebraska is not a diverse state to begin with, right? Like, where are we starting out from? And I get that, but these are not mutually exclusive. There is an opportunity and a need on the university, the UNMC as a broader institution, to really focus on increasing the diversity of the healthcare workforce that we are training across all of the health professions, right? And so this means that the work starts even before our entrance into medical school, nursing school, all of the health profession schools. It means that we have to really prioritize getting into communities where folks, kids who are running around, who are not sure what they want to be yet, and are being told maybe by high school counselors or other middle school counselors that they have to go down one path, that sports is going to be the way for them and not science and not medicine. We have to, as a medical community, have got to move ourselves into our community and say, we want to show you that you can be whatever it is that you want. And if you are interested in being in healthcare, we're here for you from as young as you are, all the way up. But it doesn't stop there, because we have to recognize that there are people who they encounter challenges along the way, right? We talked a lot about some of the financial disparities and the fact that some people, they may be working 2 jobs and so they can't go volunteer. How does the medical school help these students and provide them with opportunities that they may need in a non-traditional way so that they can still get exposure to healthcare as a preparation to bring them into medical school? Once we're talking about residency programs, yes, we want to focus on Nebraska, but so the data has shown that when we're looking at where folks stay after their training, it is not where they went to medical school, it is where they do residency. Okay, so we want to focus, yes, on increasing diversity in our medical school, but if we are really consistent with our residency recruiting and demonstrate to our applicants who are coming here that we care about them, that we want them to be here, and that we want them to want to stay, they will stay. I mean, who here is not from Nebraska, who didn't expect to be in Nebraska, and then they came here and they were like, oh, wow, this place is pretty neat. I like this university. I want to stay here, right? And so we have to make sure that we can recruit people so that they can know that they're valued and that they belong. I think the other question was about visas. I'm not sure what the specific question is. The visas visas are always challenging because I think there is a component of not on a residency or fellowship standpoint, there is a component of not having a lot of control over how many individuals with visas that you are able to accommodate in the training program and how that works. And I don't have all of the details on that, but I think what we can do is when we're having conversations about students who may be from underrepresented groups who may need visas, really thinking beforehand, like what will be our plan and what can we afford, and what are the institutional barriers that we may come up against with regards to visas, and how can we try to anticipate those so that once we go into the recruiting process, we are not feeling like we're losing out on amazing candidates because we don't have the capability to sponsor visas for them. And I hope that answers somewhat a question, but I'm not sure exactly what the visa question was, so did my best.
No, that was the whole talk was amazing. Thank you.
Thank you.
Do you want to say something, Dr. Woodard? Okay. I think there was another comment about when you were talking about recruiting and applications, would helping our faculty learn how to be better letter writers of recommendation help with the process, was the question.
Great question. I would say yes, all around. There has been a number of studies that have looked at quality of letters of recommendation and evidence of bias in the language that is used. A lot of that work refers to gender bias. And actually, there was at least one paper that was authored by our folks here in UNMC. Drs. Wendy Grant and Erica Hoffman were authors on that, and basically talked about how different words that are being used have more subconscious connotations to leadership and hireability, and other words more that are more communal, that may have less strength when it comes to how confident the letter writer is. I'm not aware of, I haven't seen a lot of research yet about that with respect to underrepresented individuals. However, I do, just anecdotally, I think that there is a benefit from coaching our letter writers to use words that are uplifting, to use words that demonstrate the capabilities of the individuals, and focus less on, what their perceived sociodemographic challenges might be. And here's an example. It's a gender example, but I think you'll get the point. Such and such, so-and-so is a fantastic doctor, and she was able to accomplish this goal of writing this manuscript despite the fact that she had 3 kids at home and, a husband or whatever. That doesn't need to be in the letter, right? If the person did a good job of doing the manuscript, you talk about the job that they did with the manuscript and leave the other stuff out of there, because that can only hurt the applicant. Because what the reader is going to think about is, oh, wait, does that person have a lot of stuff going on? Maybe I shouldn't hire them because they may be too distracted. Or maybe they might want to have more babies down the line, or whatever. You don't want to have that as part of the letter writing process, because it will hurt your applicants or your trainees.
Thank you so much. This was amazing. There were a million thank yous, and thanks for having this discussion. And I think you really elevated the conversation. So thank you so much.
Well, thank you all. I appreciate you hanging out with me here for this hour. And if anyone wants to touch base with me afterwards, feel free to do that. Thanks.